Welcome again to Forward Together, where science, ethics, and religion intersect in a changing world of the AAAS DoSER program. This is a breakout session on public health. My name is Se Kim, and I will be the moderator for this session. Before we start, I've been asked by the DoSER staff to provide some announcements. First, this virtual platform allows us to gather from all across the world. And I want to acknowledge the diverse Indigenous people on whose ancestral homelands many of us stand. AAAS is located in, and I'm joining you from Northeast Washington, D.C., which is on the ancestral homeland of the Indigenous Piscataway and Anacostan people. A reminder that closed captioning is available for this session, so you can click on live captioning at the bottom. There will be a time for questions at the end. So we invite you to enter your questions, and you can also upvote others' questions as well. And finally, this session is being recorded so that others may view at a later time. Again, this is the public health session, and my name is Se Kim. I currently serve as the Director of Membership and Governance at the National Academy of Medicine. And I'm particularly delighted to moderate this session, having spent a number of years as part of the DoSER team. So I celebrate with you and everyone here and congratulating AAAS and the staff and friends of DoSER for making possible the 25 years of facilitating conversations around science and science engagement with religious communities. The public health session recognizes that more than ever, the global response to COVID-19 has pushed the boundaries on what is possible for rapid pandemic response, including vaccine development, distribution, and acceptance. The National Academy of Medicine, or the NAM, where I am at, has been very active in convening experts and health leaders to discuss emerging evidence related to COVID-19 and providing advice on future efforts and response, such as the recent international workshop on COVID-19 lessons to inform pandemic influenza response. At the same time as the expedient scientific accomplishments we've seen through the vaccine development, the coordination of public health interventions have brought to light the importance of thoughtful engagement on these issues to have the greatest impact for our society. I have observed that NAM has also given much thought to this, and as part of the pivotal consensus study released last year called Framework for Equitable Allocation of COVID-19 Vaccine. And I believe this quote summarizes our session very, very well by advising that, quote, COVID-19 vaccine allocation framework must not only be equitable, but also be perceived as equitable by audiences who are socioeconomically, culturally, and educationally diverse, and who have had distinct historical experiences with the health system. And they go on to mention the important partnerships with organizations such as faith-based ones. So I'm joined in this session by two wonderful speakers, Dr. Michaela Howells and Dr. Pamela Payne Foster, who explore these public health issues, societal impacts, and insights from their own experiences on the potential role that religious leaders and communities can play in these monumental public health efforts. I will introduce each of the panelists. Their full bio is on the event website. They will each have a few minutes to talk a little bit about their interests and their experiences, and then we'll go on to a larger discussion. So first is Dr. Michaela Howells. She is the Associate Professor of Biological Anthropology at the University of North Carolina, Wilmington. Dr. Howells is a human biologist specializing in maternal and child health with interest in stigma, social determinants of health, reproductive justice, and health equity. Dr. Howells.
Hi, everyone. Thank you so much. It's great to be here with you today. So thank you so much for your fantastic introduction, and thanks to the organizers for having us all here together to talk about this incredibly important topic. For those who are not familiar with anthropology, I'm a biological anthropologist, and I'm a medical anthropologist and a human biologist. And what that all comes down to is that I have a focus and interest in my field at the intersection of biology and culture, which puts us in a really strong position to talk about that engagement between science and faith-based organizations, and especially health disparities. So just to give you a little framework, my background, I've worked in Southeast Asia, in the West and East Africa, in the South Pacific, and also within the United States. And my work focuses, as Say had indicated, on around different types of health care disparities. These include Zika, HIV, and AIDS, disaster response, especially around pregnant women and access to prenatal care, sexual health, and the core stigma and reproductive justice. So I'm glad to be here today. I'm glad that we're having this conversation, and I look forward to this conversation.
Thank you. Next, we have Dr. Pamela Payne Foster. Dr. Foster is a public health physician who currently serves as professor in the Department of Community Medicine and deputy director of the Institute for Rural Health Research at the Tuscaloosa campus of the University of Alabama School of Medicine. Dr. Foster's research interests include health inequities and community engagement with a focus on HIV, AIDS-related stigma, and rural Southern African Americans in faith-based settings. Dr. Foster.
Hello, and happy 25th anniversary, DoSER. When thinking about introducing myself, I thought of the word non-traditional. As a physician, I'm a non-traditional physician. I'm a preventive medicine public health physician. Most physicians work one-on-one with patients. I work with entire communities, hence the public health. And so I interact closely with the public. Also non-traditional because early in my career, I engaged in this whole area of community-based participatory research, where university academicians partnered with community partners to really deal with health issues and solving health problems such as health disparities. And early on, HIV was the disease that I sort of chased. I think about it geographically because I did my residency. I started out my residency in Long Island, New York, where many of you know the epidemic in the 90s. The epicenter was New York City and the West Coast, San Francisco, California. And so in Long Island, I was able to really see the devastation of HIV, where many persons who got diagnosed in the city might come out to Long Island to die. We were one of the first hospitals, Stony Brook, that had an HIV unit and an HIV bureau when I rotated during my residency at the Nassau County Health Department. So really able to see the devastation of a disease and a pandemic. Then I moved after I finished my residency to Atlanta, Georgia, and then followed where the epidemic is moving to large cities, even in the South. When I wanted to do work and partner with my own pastor at a large church, I arrogantly, because I had seen the data, knew how important it was, and knew how the epidemic was changing, I arrogantly saw myself as the expert and didn't really interface well with her. She wanted, I think personally, she believed in some of the things I was talking about, condom use, talking about the epidemic in front of the congregation, but from a philosophical, spiritual perspective, she was very uncomfortable. And I learned my first lesson with my interaction with my own pastor, that although I saw it as an emergency, I had to really step back and make sure she was ready to partner with me as an expert, public health expert, to really take on the HIV issue. Since then, 15 years, I've moved from Atlanta and I've been in Alabama, rural Alabama, where the epidemic has chased me down to the rural deep South. And I continue to learn those lessons partnering with some of my pastor partners, not only in education, but also in research. So I just think this time in our history is so important with COVID, where some of the lessons that I've learned in how to partner with as a scientist with faith-based communities can be very useful for what we're seeing with the COVID-19 as far as testing and the vaccine. Thank you.
Thank you, Dr. Foster. So we'll start off with a short time for a discussion with our speakers. For the purposes and to facilitate our conversation, both Dr. Howells and Dr. Foster have allowed us and each other to go by our first names. And Pamela, you started us off on a question that I wanted to ask is that how much of your experience in the past and interaction of your own public health or your own research, both Michaela and Pamela, between scientific and religious communities, how much of that examples and experiences have fed into the themes and lessons learned in the current pandemic? If you could talk a little bit about that, that would be great.
Yeah, I mean, one of the lessons I learned was the arrogance of science. And historically, we've seen that over and over again, where we come in as experts, we know everything and think we know what's going on in the community, and the community knows better. I've seen that with the COVID response, particularly, of course, we found out there were just the way well, first of all, we found out that the disease disproportionately affected certain communities of color, those in rural areas who may not have had access to testing, to the way the vaccine has been rolled out. That might not have been done as equitably as we would have liked. So many lessons, I think, from the experiences I've had. Oftentimes, I've found that in public health, we are very concerned with technical aspects of public health and not the human public response and how they really have the answers to really do what's going to work best in their community. So I think that has been shown over and over again, and that's something we have to keep discussing and keep fighting.
Michaela, would you like to share your thoughts on how some lessons and in terms of engagement that translated from your own experience to today?
Absolutely. And thank you, Pamela. I think that really hit on a lot of the key components of this. We get really focused within medicine on the biological, which makes sense, right? We're trying to figure out the mechanics of the disease process, how it's passed on. And that, of course, is critical to be able to address and curtail any sort of disease situation or a health situation. But when we're so focused on the biological, unfortunately, the cultural tends to be the afterthought. And that could be, I'm using cultural here as an anthropologist, so like broadly, like in terms globally, but also different cultures within our communities and engagement with information on what kinds of education people have going into the disease process, into in this case the pandemic, right? What kinds of opportunities have they had to engage with these different health components beforehand, and then what kinds of information are they getting, and who are they getting that information from, right? So these are all components. I'm sure Pamela's had the same, where looking across her work, seeing the same, where it's like these are components that tend to be pushed off as the sort of, as I said, the afterthoughts, the things that we don't need to invest the time or energy into as much as the biological. But the reality is that without those cultural components in place and that cultural understanding in place, we are not going to be able to affect any of the change that we seek out and set out to do, no matter how much money or brain power we bring to it. It needs to be, Pamela's used the term partnership multiple times. It needs to be a partnership. It needs to be a true dialogue, not a just after the thought dialogue.
So, I've heard both of you mention this word, which is, I think, very common in science communication, which is cultural competency, and how that has fed your work. As Michaela was just expanding on, how has awareness of the context and the communities that you work with informed your work in public health and in science?
I can give one example. The National Guard came in and did some COVID vaccinations in the rural South. Their idea was to do 1,000 vaccinations in one sitting. So when they came in, the idea was we need a large enough space so that people can drive through. So it was all very technical. So that's how they decided even how to select the locations where they were going to do the vaccinations. They had no communications with the communities beforehand. One of the community members called me and said, why did they put it in this city when we really need it? They already have clinics in that city. We have no clinics. Why not put it in our community, our smaller community? And so I think that's an example of where them knowing about the landscape, the community landscape, not just technically where to kind of have parking and where people can drive in to get vaccinations, but actually having conversations with the community on what might best meet their needs would probably be a better approach.
That's a great example. I'm going to use an example from my Zika work in American Samoa, if I may. When I was landing to start the Zika work, I'd been working in American Samoa for the last 3 or 4 years at this point. And I remember the first thing I landed, I was waiting in line for to go through to get my passport checked. And the first thing I got, a friend of mine was in line with me and they're like, oh my gosh, did you hear what happened? And what happened was that the CDC had landed and recognized that Zika was sexually transmitted. And so like, okay, we need to get condoms out in the community immediately. Well, where do we do this? We do this in the churches because that's where everyone goes to church. Everyone is part of a church. Great. So they ended up coming in and doing a Zika presentation at one of the largest churches, and then passed around a giant bowl of condoms so that everyone could take some condoms with them. And this was just, it's absolute slap in the face. It's absolutely against the cultural expectations in terms of sexuality, which is a very private thing in many cultures, but especially in Samoa. And it was just seen as a complete slap in the face to the religious community and to Samoans in general. And so what that ended up doing was closing a lot of the dialogue around sexual transmission, because it was like, well, if we have any conversation about this, the giant bowl of condoms is going to come out again. And so that's an extreme example, but one that really sort of set back that kind of movement in terms of having those conversations, especially with those who are most at risk.
Can I follow up on that, say, because that example I gave you about not really partnering well with my own pastor in Atlanta, that was one of the major issues, whether or not to have condoms when we had a health fair, whether or not to have the condoms, the bowl of condoms out. Of course, as a public health professional, I'm like, of course we have to do that. That's a way to not transmit the disease. And my thinking was there was no negotiation with my pastor about that. But now I've learned, yes, there is negotiation. Maybe I still can have materials out about how to prevent HIV/AIDS and not have the bowl of condoms there. So also this partnership, and when I mean partnership, I mean really where we can pick up the phone, we can talk to each other, we can meet and discuss, and maybe some things are negotiable and others are not, to really kind of get at what the outcomes we really want. And the other lesson I learned was that everybody's not going to be ready at the same time. So with me thinking this is a crisis, we've got to deal with it this way right away. There are some who are going to come in slowly and others will go a little faster, and really just moving at the speed of the community and the community influencers, I think is so important. And of course, pastors are huge community influencers.
Thank you for that. Before I ask the next question, I just want to remind the audience, please go ahead and put any questions as you hear the speakers share. Please put any questions in the Q&A box and we'll be sure to get to them towards the end. I wanted to dive a little bit deeper and give our audience a chance to hear from your stories, from your experiences. In other words, what are some biggest challenges that you have walked through in public health communication or engagement with religious communities? And it could be either a personal challenge. I mean, Pamela, you've mentioned some personal lessons and growth. Thank you for sharing that. But it could be personal or it could be systemic or structural. But what are some biggest challenges you've encountered? Who would like to go first? We'll start with, yeah.
I'll start. One of the things that happened with me, we do have these light bulb moments as researchers. I know Michaela's probably had it as well. I was so focused on getting numbers of pastors to buy into what I wanted to do around HIV prevention. Numbers, numbers, numbers. And then I was interviewing 8 pastors in rural Alabama. And I said, a light bulb went off and said, you know, these pastors want to do HIV prevention. Why don't you flip your script from just focusing on those who don't want to do it and flip to the ones that do? And what is it about these pastors that make them good profiles for really partnership around HIV prevention? And so that's what I did. And one of the things that was so fascinating was all of them were, and I wrote a paper about this, all of them were reverse migrators. So if people know African-American history, you know that many in the Deep South migrated from the early 1910s to 1970s out of the Deep South into the North and to the West. So now there's a reverse migration going on where African-Americans are moving out of those areas back south for various reasons. They, have land, their family has land, they have older relatives who are sick, they want to take care of them, or they're retiring and it's cheaper to live in the South. So they were all reverse migrators. It was something about them. They had grown up in Alabama, they left, and they went to large cities and came back. So and then there were other commonalities. Many of them who were pastors were married to nurses. All of them were male. So they were connected to somebody in the healthcare field. So that kind of flipped my switch from always kind of focusing in on the people that I couldn't partner with to then kind of flip to who can I partner with and really do this work.
I love that so much. I love that you're talking about the diversity of these faith leaders and what they're bringing to the table and how they might interact with that information differently. I think that tails really well into my experience, where I realized over the years as a scientist that I had some more monolithic views of different faith communities, right? Oh, these faith communities are very similar, so they would act this way or do this way or respond this way. And I really needed to, really think about that and learn more. I needed to put a lot more time into understanding different faith communities and expectations, and then also the different cultures within the individual churches. Now, sometimes there's more time for that than others, depending on the situation or the number of people that you're trying to interact with. But that was a big eye-opener for me, as was, and this, Pamela, this goes with what you were referring to earlier about like, oh, well, they're open to HIV/AIDS prevention, but maybe they need it in a different way or fitting. One of the things that I've really more fully recognized the critical nature of is that individual faith leaders may have a certain perspective on items. Of course, they're humans. They're coming to the table with their own perspective of what they would like to see done. But also there's the church doctrine, right, about what they can do. So I work with a Catholic nun who is very much, she would love to get condoms on every table, and like Pamela's kind of idea there. But also that is not something that would be appropriate through her leadership, right? And so she's found throughout her work ways of ensuring that those condoms get in people's hands, but also fit within the role of the church's expectations. And that's critical on multiple levels, but part of that is like, the where the funding is coming from. So for many outreaches and organizations, those can be funded by the churches. And so being able to, I want to say like meet them where they are, but the reality is understanding, that comes back to that cultural competency, understanding where the limits are, and then where those those limits can be modified. Like Pamela was saying, like what are those conversations that can be had, not to try and change people's minds necessarily, but to ensure that we're not going in with this idea of like, oh, well, this is your view because you're part of XYZ church, but actually having that open dialogue.
Thank you. A lot of good nuggets there. I want to go a little bit deeper before we come back on a positive note, which is, I think COVID brought us, as great as the vaccine science was, it brought us a lot of challenges, as you've highlighted. What are some misconceptions, both from scientific communities and religious communities, that you have seen that we can do better on, that we can help each other understand more in terms of public health, whether it's COVID or your other work that you've done? Common misconceptions when it comes to communicating these.
So a lot of people I know in Alabama are very for the vaccine or anti the vaccine, but a larger number are in the middle, sort of in the fence, sort of contemplating it, but not quite there. Some of the things I've heard are that the vaccine came out too fast. And we know in science that we've been working on coronaviruses and vaccine development for a long time. So that's not really true. Everything sort of got pivoted and put into high gear for COVID-19 because of the awful death rate. But we've been doing this kind of work for a while. So that's a hard one to turn around. There is true distrust of communities with governmental research. I heard over and over again, Tuskegee, I'm in Alabama, so I hear the Tuskegee syphilis experiment. We call it the U.S. Public Health Service syphilis experiment. So those are things we have to continue to have conversations around over and over and over again. I have colleagues at the National Bioethics Center who really talk about, rather than us being trusted, that we have to earn trustworthiness. We have to be trustworthy. And that can't just start when we start with the COVID-19 vaccine or the pandemic in 2019. We should be really trying to develop trust, the kind of trustworthiness, so that when something urgent happens, then the community can come to us. That's what I hope has happened in my career, where people pick up the phone and ask me, can you come and talk to a group of us about, what's the best mask to wear? What is this virus? And what about the vaccine? What about the side effects of the vaccine? So those are things I think we have to continue to work on as a scientific community.
Thank you. Goes back to personal relationships, break down those miscommunications.
Yes.
Michaela, do you have some examples of miscommunications or misconceptions that people have come across on both sides?
So I'm going to take a little different tact on this answer, because I think Pamela hit on many of these that are coming across, but this comes back to the actual engaging with the communities. I thought the National Guard example is a strong example of that, right? I think there's a misconception that having conversations with the different groups that you'll be working with, and these conversations, having these dialogues, that that those can wait until everything else is in order, right? Like that's the last phone call to make that, hey, we're coming into town. And that those conversations, not only that can they wait, but they're again, like the least important, or one of the lowest component. And in fact, that would be something I would urge people to think about in terms of having that conversation early. And that's been hard. I mean, for me, I'm trained to do that. And still, it's like, I feel almost guilty calling someone or talking to someone, emailing someone when the plans aren't in place. I'm not sure if it's going to come to fruition. The money might not be there in terms of like grants, right? We have these really long periods of time, but the most successful, hands down, in any of these partnerships I've had is when it's absolutely from the get-go and we're having those conversations. And also it saves a bunch of time and energy, because communities they're incredible in terms of trying to address their own needs. And so being able to talk to them and know, okay, here's what needs to be addressed and how can this partnership work? We hear that over and over, but again, over and over in research design and project design and health implication design, we wait to sort of deliver this material without it being in that conversation. And part of that view is that it's expensive to do that. It's time consuming. I will a little shout out to Anthropology here. I'll remind you that your friendly neighborhood anthropologist is probably someone who you might want to partner with or think about partnering with, because we have a toolkit to be able to engage with communities in a different way. We might be engaged in a way. So in a World Health Organization, the Ebola outbreaks, like the not this current one, but the one previous, they brought in a team of anthropologists because not only did they speak the language, but they were also able to, like, they knew the cultural setups of the community and were able to engage in that cultural component, which enabled the biological work to do. So again, this goes for COVID, it goes with any communities that very early communication, that ongoing communication, and that honest communication. Right? People know when they're being used as a tool and when they're actually part of a partnership. And so those are, it's a challenging part, but again, I think that's just about changing how we view it as scientists and how we think about it in terms of where that conversation needs to take place within the research.
I just want to follow up quickly, say, just on the importance of the multidisciplinary. I absolutely agree with Michaela that some of this is because we're all sort of working our silos, and a sort of multidisciplinary approach is a much better product at the end, really when you're dealing with such complex cultural and public health issues like COVID. I'm a part of a team that's led by an anthropologist. So funny. And we were looking at the equity rollout of the vaccine. And her approach is very different than mine, but it really is good to kind of bring us together. The second point I wanted to say is that we have to keep our systems accountable around these issues. Someone from the public health department called me in 2019 to ask me who the community groups were in Alabama that they needed to partner with. And they just wanted a list, say, tell me who they are and give me the contact names. I said, well, don't you think you should set up a meeting and talk with them? Besides just the list, they just wanted to tick the list off. And so that was and so what's happened is once everything started getting bad in 2020, then they had to deal with the vaccine, they were sort of chasing their behinds, when if in 2019 they had sat down and talked and done some of this community engagement early, they wouldn't be chasing their behinds. So I think we're going to have to make systems accountable. It can't just be me and Michaela really engaging with the community in our own settings. It has to be state health departments. It has to be governors, because some of this is political as well. And that's where faith leaders, I think, also can help with making systems accountable to public health crisis.
Those are really great points. I heard relationships and partnerships, early engagement, accountability of systems. And I know in previous conversations, you've highlighted that, it isn't just you, Pamela, and Michaela, but if we can get lots of Pamelas and lots of Michaelas, then we can create that change in our system. I do want us to go to our conversations and questions from the audience. We had one who asked, during the COVID-19 pandemic, how have you seen religious leaders and communities effectively help overcome mistrust of medical and scientific institutions in historically marginalized communities due to the long-standing disparities in access and ethical research and treatment? So I guess they're asking for some positive examples of religious leaders and communities helping overcome those.
So I was talking about that Communivax project. It's a national project, and Alabama's one of the sites. We did some in-depth interviews. I was just overjoyed constantly when we interviewed rural residents, how churches really stepped in to fill in gaps. They got people signed up for vaccine. They transported them. They dealt with the food insecurity. They, advertised, sent people information. Well, one of the persons set up a community resource center. I mean, communities have their own answers, and often churches are at the center of that with really doing the positive work. I'll give one example of a pastor who weekly has done a newsletter where he talks about the rates in his county, where people can get testing, where they can get vaccine, and really acts as a resource to the community. And I think that's been shown with this pandemic.
Michaela, do you have an example you would like to share about religious and leaders and communities to overcome that mistrust, or expound on anything?
Yeah, so certainly the ability for faith leaders to have the toolkit to be able to speak to their communities knowledgeably is a big component in terms of helping connect with the communities in general. And it's seeing those community leaders and faith-based leaders speaking to their churches, being able to just share pieces of information, whether it be in the church newsletter or actually from the pulpit, whether those conversations after. I mean, we're in a different space, right, because of COVID, exactly. But what I'm seeing, at least in our community, for instance, is we have a lot of pastors and faith-based leaders who are using their time as they're interacting online with their community to remind them that they want to be back in person, that they can't wait for the community to be in person together. And part of the way that we do that is by getting the vaccine, is by helping get your neighbor to get their vaccine, reminding your children. We saw that during, for instance, during the election, and then also with COVID, we see that Black women in the community are the ones who are making this happen. And so they are driving their family members to get their vaccines. They are making their nephews and nieces stand up and pay attention and get in there and get it. And when we're talking to them and asking them about like, why do they have the drive? And part of that answer is the community-based, and part of it is the faith-based, right? Where it's like, we're getting this message out, let's bring this. And so it trickles through. But again, it's that space and what faith-based organizations do for people in terms of helping protect them. And obviously not all faith-based groups are doing that, and not all it's not even denominations, not all groups are doing that, but the ones who are really helping support the movement and towards greater health.
Thank you. I'm distracted because there's so many great questions coming in, and so we're going to do what we normally do in person, but we're going to do it virtually. We're going to do a firestorm of questions, and you can pick all three or one to answer, or like just hodgepodge it. But you have to do it in a minute because we have 2 minutes left, so a minute each. Really quick, the three questions are: what are some future issues that you see upcoming? And in light of that, how do we train future leaders in science and public health? And third, end with any advice on dialogue and how to facilitate interactions and engagement with religious communities. So those are the three. So we'll start with you, Pamela.
I think emerging infections are going to be something we'll have to continue to pay attention to. I think that public health education probably needs to be infused into curriculum. Medical students probably need to know a little bit more about public health. Faith leaders probably need to know a little bit more about public health. And so infusing some of these topics into the curriculum for our future trainees is probably the best way to handle it.
I agree. And I would come back to cultural competency and training cultural competency, and not just saying like, okay, you need to get culturally competent, but giving them the toolkits for this. So for instance, our public health and our global health students have to take medical anthropology as part of their requirements. And part of that is so that they actually get the training and the toolkit to be able to recognize how to get information on communities, how to understand variation, and how understand diversity on a global level, but also on a community level. And again, it doesn't have to be anthropology, but certainly recognizing the value of that, and it not being just, here is a 1-hour lecture in the middle of your public health program or your medical program, but actually having dedicated course time and recognizing that as this is so valuable, we need this as part of the curriculum, that changes can be made and are being made. And
I know we don't have much time, but we've got to deal with systemic racism as an issue, and it's very controversial how to do that. Implicit bias, cultural competency, as Michaela said, but we have to kind of think about how we're going to do that at all levels of education.
Absolutely. I'm sure that you both are a resource abundant. So if the audience have any questions through DoSER, they probably can reach out to you. I'm volunteering you. But thank you so much. I want to ask the audience to join me in thanking Dr. Foster and Dr. Howells. I take home with me, and I hope you do as well, that small steps, as Dr. Howells said, lead to larger changes. And so I encourage everyone to take part in communicating for the goodness of public health and society. Thank you again, Dr. Foster and Dr. Howells. And again, congratulations to DoSER. And I believe you can go back to the agenda and click on the next session of interest. So
Thank you.
thank you.
Thank you.